Okay. Brilliant. So, hi everybody, and welcome to the panel on Displacement and Disease, a discussion on the effects of COVID-19 on displaced people around the world. I think I speak for everyone when I say we're really excited for this panel, as COVID-19 is obviously at the forefront of everyone's mind. And this panel will allow us to focus on how this difficult situation is affecting others around the world. COVID-19 has highlighted the importance of inclusion of migrants and refugees in all phases of the pandemic response. Migrants, refugees and asylum seekers have often not been explicitly included in public health and health system responses to the COVID-19 pandemic. This has resulted in these populations facing increased challenges in accessing healthcare and being disproportionately impacted by restricted public health measures. For this session, we're very lucky to have 5 panelists with expertise all over the globe. The first speaker is Dr. Miriam Orcutt, who is a senior research fellow in global public health and forced migration at the Institute for Global Health, University College London, and executive director of Lancet Migration. She is a trained medical doctor and works regularly as a public health and humanitarian consultant on migration and health. The second speaker is Dr. Borhade, who is an associate professor with the Indian Institute of Public Health in Delhi. She has a Master of Public Health, a Master of Social Work, and a Diploma in Labour Laws and Labour Welfare. Currently, she is a research fellow under the Wellcome Trust Capacity Building Programme, focused on comparative research on health policies for migrant workers in low, middle, and high-income countries. The third speaker is Dr. Guinto, who is a physician and public health scholar practitioner, working at the nexus of global health and sustainable development, with a special focus on environmental health and migrant health. Dr. Guinto is currently a consultant for USAID on the impact of COVID-19 on migration in Asia and the Pacific, and he previously served as consultant for the International Organization for Migration to help establish the Migrant Health Program of the Philippine Department of Health. The fourth speaker is Christy Braham, who is the founder and coordinator of African Platform for Migration and Inclusion in Health, a research and advocacy organization focused on the health of migrants across Africa. She is an interdisciplinary public health researcher with experience working on NGO, governmental, and European Union projects aimed at improving the health of marginalized populations across the world, most notably displaced populations and migrant worker communities. She holds a master's degree in public health, a biomedical science degree, and is finalizing a PhD in public health and migration at the University of Sheffield. The final speaker is Dr. Sedas, who is an American-Mexican physician, especially interested in the intersection of migration and health. She worked as the head of the health window at the Consulate General of Mexico in Boston and has networked with Latin American consulates to create culturally sensitive medical education and free health services. This year, she led the situational briefing on migrants and refugees in Mexico during the COVID-19 pandemic, published in the Lancet Migration portal, and collaborated with the Center for Health and Human Rights in a joint memo on protecting human rights of children during and after the pandemic per request of the UN Special Rapporteur. Each speaker will now introduce their area of expertise and then begin to compare their experiences to cover how COVID-19 is impacting migrants and displaced populations around the world. They will cover the responses of governments, civil society and the international community, and finally discuss the challenges and potential solutions to protect the health and well-being of migrants and displaced populations in the time of the pandemic and beyond. Over to you, Dr. Orcutt.
Thank you so much. Thank you for the invitation. It's a real pleasure to be here. And I'm first going to start by giving a little bit of a global overview, especially from the work of Lancet Migration. And I really look forward to the rest of the panelists and colleagues' presentations from their regional and national contexts. So the other week, Richard Horton wrote in The Lancet that during COVID-19, interactions of multiple conditions and risk factors are occurring in social groups according to patterns of inequality deeply embedded in our societies. Migrants are one of the groups that often face an interaction of these multiple factors and patterns of inequality, which make them higher risk for both COVID-19 infection in the first place, as well as potentially for high morbidity and mortality from COVID-19. And this is particularly due to the fact that, as we have seen, both the pandemic and the economic impacts have exacerbated both large gaps in access to and quality of health services, but also existing inequalities within our societies. What has come out through our work at Lancet Migration during the COVID-19 pandemic has been that many of these pre-existing structural factors are now exacerbated by COVID-19 and often have some of the biggest mental and physical health impacts on migrants, asylum seekers, and refugees. So just in terms of a little bit of an overview of what we found so far, the four main factors that we have seen across different contexts which have been having an impact on these populations are health system factors, which might include things such as barriers in accessing healthcare, whether that be language barriers or barriers due to immigration status. And this can be particularly for those who might be of undocumented or irregular status. Broader socioeconomic factors have had a huge impact on many of these groups during the pandemic, not only because of a worsening of their existing often poor and crowded living conditions, particularly in contexts such as detention, but also because of increased economic precarity. So unfortunately, the impact of COVID-19 on many, for example, low-wage migrant groups has been rising unemployment, loss of livelihood, and also a reduction, if you look at remittances globally around the world, a huge reduction in remittances. But then there are the broader political factors. And what we actually noticed pre-COVID-19 was that there were already a feeling of policies being founded, migration policies being founded often on a background of xenophobia and even racism. And so sadly, these already disadvantageous immigration policies have only been strengthened often during COVID-19. I'll mention a bit more about that after. And then finally, protection factors, which are often mostly affecting individuals who might not have legal status. So asylum seekers who are just in the process of applying for their asylum or waiting for their refugee status to be determined have often found themselves caught up in a state of limbo where they have reduced access to the asylum process. But we've also seen, sadly, an increase in deportation and detention during COVID-19. So as you can imagine, many of migrants, asylum seekers and refugees therefore face a sort of combination of these factors: health crisis plus socioeconomic, and then a failure of protection mechanisms, which are all being exacerbated during COVID-19, sadly. I'm just going to give one brief example of this sort of intersection of risks. Of course, there are many other examples, but of non-communicable diseases. So we already know that poverty and socioeconomic inequality is closely linked with non-communicable diseases, and that most occur in low-income countries. There were already major gaps and failures in addressing NCDs prior to COVID-19. However, during COVID-19, we've seen a further diversion of funds away from NCDs to focus on the short-term emergency response, and less of a focus on long-term sustainable health system response. If we just look at one region in the Americas, PAHO did a rapid assessment of service delivery for NCDs and found that unfortunately 89% of the countries across the region reported that their health staff who would usually work on NCD services had actually been pulled into the COVID-19 response, whether that's full or part-time. A modelling study in The Lancet suggests that 1 in 5 people are at increased risk of severe COVID-19 as a result of underlying NCDs, and we do know that migrants and ethnic minority groups already had a high proportion of NCD burden. For example, just in one context, in Greece, among the asylum seeker population, MDM found, one of the NGOs found pre-COVID, that they had a 40% disease burden related to NCDs. So far, as of the end of September, UNHCR has reported 25,151 COVID-19 cases among forcibly displaced populations, and just 247 COVID-19 deaths. However, with reports from the field saying that there's high numbers of underreported cases, for example, especially in contexts such as internal displacement, for example, in Syria, or refugees living in informal settlements in Lebanon, or asylum seekers who are in transit situations across the world, this number seems very likely to increase. However, it has also been raised recently that there has been less transmission of COVID-19 seen in some closed settings, particularly some refugee camps, and it has been suggested that this might be partly due to the generally younger age of some individuals in refugee camps, such as, for example, this has been noted in Cox's Bazar in Bangladesh. But of course, the COVID-19 pandemic doesn't exist within a vacuum, and very much what we've seen throughout the pandemic is that, and also migration exists within this broader context, is that we can see the impacts of what was pre-pandemic an already weakened international system, a retreat on global commitments and multilateralism, and also a global refugee protection system that wasn't being upheld. So we know that the Sustainable Development Goals won't be met unless socioeconomic inequalities are directly addressed and those furthest left behind are explicitly included. However, the health system response to the COVID-19 pandemic has demonstrated that we are increasingly leaving some of these most marginalised communities even further behind. Certainly what we've seen to date when we looked at the health system responses to COVID-19, particularly with focus on migrant groups, is that there has been a lack of responsiveness and resilience demonstrated in health systems to adapt to the needs of people during COVID-19. And one of the challenges often with health systems addressing migration, even pre the pandemic, is that health systems and health services are usually defined by geopolitical borders. And this has become even more marked during COVID-19 when we've seen a lot of border closures, for example, and individuals who've had movement restricted. Of course, migrants in different phases of migration, as you can see in this framework, will be affected in different ways by the health system responses to COVID-19. For example, those who are in a transit phase who might be living in an undocumented or irregular status have, unfortunately, during the pandemic become more vulnerable to being stranded, experiencing family separation, or being exposed to human smuggling during COVID-19. At Lancet Migration, we've been compiling a series of country, regional and thematic situational briefs, which you can find on our website, and we now have 22. I want to thank all of the Lancet Migration team, as well as our brilliant country authors who've worked over the last 6 to 7 months on this with us. And what we've seen in terms of the main themes emerging about the health system response is that inclusion of migrants and refugees has been limited during COVID-19 by 4 main factors. One is primarily a biosecurity-driven response rather than a response that's rooted in public health, principles of inclusion and right to health. But then also that restrictive measures of lockdowns, whether that's travel restrictions or physical distancing, are often imposed more severely on groups of refugees, asylum seekers, migrants, and not necessarily proportionate to public health need. For example, in Greece, asylum seekers and refugees in camps have been under lockdown now for 8 months, since March 2020, even though there were no cases of COVID-19 on, for example, the island camps until the beginning of September. The other 2 themes that we've seen emerging are insufficient resource allocation to ensure inclusion, and also generally poor access to healthcare and health promotion services. I'm just going to mention briefly about the biosecurity-driven response, because, as I mentioned, there's been an increase in, for example, hardening of borders or border closures, which we've seen very much globally during the height of the pandemic, particularly. But also we've seen a suspension of both asylum processes. So, for example, in the US, since March 2020, asylum processes were suspended. And in Greece, there was a suspension of asylum procedures from March to May. And UNHCR has shown that 72 countries in June 2020 were denying access to their territory for asylum seekers. So even if you were seeking to go through the asylum process, you were not able to. But there's also been the suspension of resettlement schemes. So those who are most vulnerable not being able to be resettled, even if they had already been allocated under a resettlement scheme.
Sorry to interrupt, Dr. Orcutt, that's the first 10 minutes.
Okay, sure, I'll just finish off quickly then. So really, one of our concerns is that there is a need, a global need for urgent inclusion in the health system response for these groups. And these are the 3 main things that we called for actually at the beginning of the pandemic, including access to health systems, preparedness and response, but also addressing some of the broader determinants of health. And really, you know, as I said at the beginning, it is, in order to effectively address the pandemic, there is a real need to consider not leaving anyone behind and explicitly including these groups such as migrants, refugees and asylum seekers. Thank you.
Thank you very much. So our next speaker is Dr. Borhade. Are you able to share your screen, Dr. Borhade? We can't hear you at the moment.
Can you see the screen?
No, not yet.
Okay, I'm sorry. Yes. Is it visible now?
Yes, brilliant. Thank you.
Well, thank you so much for this opportunity. I'm going to share my views and some of the facts and figures in Indian context related to migrants and refugee and the COVID situation. I would like to give little bird eye view about the urban migration and displacement in South Asian region. South Asia have had a long history about the migration and displacement. In India alone, we have almost 120 million migrants who are internally moving for jobs. Regarding the refugee population, we have almost 3 million Afghan refugees in Pakistan, more than 1 million Rohingyas refugee in Bangladesh, and overall almost 4 million new internally displaced persons from conflict and disasters, which is coming from 2018 data. If you look at the number of migrants in CRO countries, you can see the countries and the stock of migrants. The highest migrants are in India. You can see almost 5 million, followed by Thailand, and later followed by Bangladesh. Regarding the internal labor migration in India, it's a large-scale interstate and intrastate migration for livelihood because of multiple number of push and pull factors. However, there is no officially consistent data available in India. We have 55th round of national sample survey, which estimate almost 30% of migrant workers, 30 million migrant workers, and National Commission for Rural Labor estimates almost 10 million migrant workers. However, it's a 10 years old estimate. Some private studies had estimated almost 120 million such internal migrant workers in India. The key challenges workers facing the overall in South Asia, as I mentioned, almost 40% of world's poor being hit hard during COVID times in South Asia. In India alone, almost 400 million workers were at the risk of job loss, and the immediate lockdown left millions of these workers without jobs, shelter, and almost, they were on the verge of the starvation. Closure of work sites and the eviction by landlords and the employers triggered this mass exodus of migrants who faced multiple issues, including, reaching to their hometowns literally by walking down more than 100 and 1,000 kilometers to reach to their native places or the source areas. The key challenges these workers faced during this COVID time was there were because of the sudden lockdown, of course, government raised immediate emergency shelters, but not all migrants could avail the shelter facilities. So living in cramped conditions without access to water and sanitation facilities was a key challenge, particularly in the metro cities like Mumbai. These workers were employed immediately after the lockdown was lifted into a sector which kept them into close proximity with the other workers. They also had limitations to access healthcare services and information, basically due to lack of documentation and financial protection. And there was also fear of detention and deportation in terms of the international migrants, especially who are coming from other countries, especially with the Nepal border or the Bangladesh border. India government announced many relief measures and the economic support packages, but many migrants couldn't avail it because they didn't have the official documents to access that support. So this all situation basically demands for the strategies which needs to be address migrants' needs with more human rights or the public health approach that can focus not on only on the health issues but also on the other social determinants of health and also the multiple category or different categories of the migrant workers. So when as a public health professional or a human rights activist, we are working with workers, I think it's very important for us to deliver this awareness among the migrants, what they need to know to protect themselves as a migrants. So first and most important is their rights to access health services, safe housing and rights in general, irrespective of their migration status. And do's and don'ts during COVID times, particularly the food and nutrition support available during the COVID time. It could be through the civil society or through the government. Then the social distancing norms, even within the family and at the workplace and in the public places, basically the protective measures and all the government schemes and programs which are meant for them in terms of shelter, health and social security programs. When we are working as a public health professionals, basically as a responders or the communicators, I think it gets far more important to educate ourselves on certain aspects of migrants and what needs to be done to protect the migrants. I think first and most important is protect ourselves first to protect the migrants. So it's basically, it's important to understand do's and don'ts to safeguard yourself first against COVID. So it comes in my mind the example of the guidelines or the SOPs for the protection and service delivery for the healthcare staff or the public healthcare staff during COVID, particularly for the shelter, quarantine homes, travel support, etc. I would like to give one very small example in Indian context. When the government of India raised emergency shelter for migrant workers, the execution staff which was deputed on this shelter for the management, this staff had no clue how to work with migrant workers. For them, it was a complete new population category and they never interacted. All these deputed people were either school teachers or the other health staff which never came across with the migrant groups. So it was completely new field, first of all, to handle the emergency shelter for migrants, understanding their psyche, and then provide them support in the shelter for next 2 to 3 months. So that need came from the staff that, you know, there is no guideline or SOP developed so far because it was completely emergency and new area. So a new guideline was developed for them with the district and state health office. And we delivered that guideline for the staff. And then again, a new requirement came from them that, you know, we are actually dealing an emergency situation and we really don't have time to go through the manual or a guideline. It would be fantastic if you can give us a video form, you know, messages or the do's and don'ts. So then we have to transform that guideline into a video form. So my point is basically as a caregiver, we need to have easy to understand and easy to accessible do's and don'ts in such situation. It was in COVID this time, but it may be another emergency. So we need to be prepared for those. The second most important is awareness on the facts about migrants. For example, among many health care providers or even other professionals, it is a common bias that migrants are carrier of diseases and they are generally into poor health and they are a burden of healthcare system. When they are coming to destination cities, the local health system is not well equipped with the available or the ready resources, but which is not true. I mean, as per the healthy migrant hypothesis, migrants are generally a healthy group which decides to migrate and succeed only when they are into good health condition. But that situation or that advantage may decrease with the time when they are migrating to destination cities, and mainly because they don't have easy access to the local health care and local health system that may affect their health in a negative way. I have given a reference of one of my Lancet comment on this, and again with reference to a larger study which was conducted on the healthy migrant hypothesis. So my submission here is, as a healthcare professional, we should be aware about the migrant health situation and the myths and the facts about it. The third most important area is we should ensure migrants are treated humanly and protected against the stigmatization and violence. Again, I would like to give examples of Indian context. I mean, during the lockdown period, many villages didn't allow their own people who were returnee migrant in the village, and again with the because of the fear that they might be carrier of the COVID. So,
sorry to interrupt, Dr. Borhade. That's 10 minutes.
Yeah, I will try to finish in the time. So basically, as a healthcare professional, we need to develop migrant inclusive response for the benefit of the entire community, both local and the migrants. Continuity of the care and the humanitarian assistance should be ensured to emergency shelter, housing, and other social security support, and developing a comprehensive contingency plans to follow the healthcare public health guidance for collective sites, refugee sites, informal settlements, as well as the immigration detention facilities for international workers. I would like to share briefly about the response of government, Indian government, to support migrants during the COVID time. Indian government actually applied National Disaster Management Act, and as per the act, the emergency shelters for migrant workers with basic amenities and medical services to protect them against COVID-19 were raised almost in all states of India. There was a comprehensive advisory guideline issued to all states to provide travel support to internal migrants as well as the international migrants, and almost 10+ million migrant workers were repatriated. Almost $24 billion relief package was developed under PM Poor Welfare Scheme, especially to boost the employment and livelihood opportunities both in urban areas as well as in rural areas. So these are just a list of few schemes under this larger package. There is a specific initiative to address the indigenous livelihood migration in India because our national and regional data shows that internal migration within India is highest among the indigenous population, followed by scheduled caste and other backward class groups. So the ministry meant for the welfare of this group is called as Ministry of Tribal Affairs. They conducted a national study on tribal livelihood migration. Basically, it was a situation analysis, gap assessment, and future recommendations to develop a national action plan. This study was fortunately completed in January 2020, and this study was led by our foundation, Disha Foundation. Based on this study and in the light of COVID, Ministry developed a national migration data repository, basically to capture the tribal migrants data and to build more evidence-based programs and policy, because the studies, one of the studies recommendation was the biggest gap of lack of data on migration. Second important initiative by government is development of information manual, that is for the pre-departure and on-arrival information, basically to empower tribal migrants to access and demand social security, health, and other services at the source and destination location before and during the migration. And the ministry is also working with states to initiate state-specific migration support program in convergent action. And all this has been launched under the umbrella of a Center of Excellence in Migration, Health and Development at Disha Foundation. So basically, Disha Foundation will be playing a role of technical coordinator to anchor the above mentioned activities. Do we have 1 minute more time, Will? I would like to show a very brief video about this initiative.
Yes, of course, go ahead.
Shram Shakti, National Tribal Migration Repository, Digital Data Solution. Affairs conducted National Study on Tribal Livelihood Migration. Study revealed that lack of migrant-specific real-time data is biggest challenge for the state and national governments in formulating effective strategies and policy decisions for welfare of migrants workers both at source and destination states. This has been realized strongly on many fronts in the light of facts and circumstances in the prevailing COVID-19 situation. Ministry of Tribal Affairs has taken proactive step and launched Shram Shakti, National Tribal Migration Repository, to bridge existing data gap and create evidence-based policies to address the welfare of tribal migrants in India. This repository will capture data from both villages and cities through web portal and mobile application. The data of migrants will be recorded in 4 segments: demographic profile, livelihood, skill mapping, and migration pattern. Artificial intelligence will be employed to create basic and predictive analysis to help state and central governments for formulating evidence-based strategies and policies to support tribal migrants. The migration data will be electronically available and visible via dashboards at village, block, district, state, and national level for different tiers of government authorities. Alongside, Ministry of Tribal Affairs also launched training manual for domestic migrant workers of India, named Shram Sathi, Pravasi Shramik Margdarshika, to increase awareness and knowledge on livelihood, social security, financial, legal, and health aspects among migrants. It is expected that migrants will be able to demand and access services, rights, and entitlements related to livelihood and social security at their village before migration, as well as after migration at destination towns and cities. Accordingly, training manual is divided into 15 modules to provide comprehensive information to workers. This training will empower them to make informed choices while engaged in the process of migration.
Thank you for that, Dr. Borhade. In the interest of time, are you okay if we move on to Dr. Guinto? Thank you.
Yes, thanks so much.
Sure. Good evening from the Philippines. Can you see my slides? I want to make sure.
Yes, we can.
Okay, great. Thank you very much to the Students for Global Health in the University of Plymouth for this opportunity. It's glad to be with Miriam and Anjali and Christy and Anna. It's just like a reunion of the migrant health scholars and practitioners. We're not that many in the world, so it's great to be in this panel. So for the next 10 minutes, I'm just going to give you a survey of the major challenges, issues that migrants, different types of migrants are confronting in Southeast Asia as we tackle and undergo this pandemic of COVID-19. And so I just want to bring you to my region. It's composed of 10 countries, as you can see. And the ones that are encircled in red are the countries that are predominantly receiving. They receive migrants, particularly migrant workers. And then the rest are predominantly countries. And so, the region is really a microcosm of migration and health, of different kinds of migrants. And definitely because of COVID-19, these migration experiences have been really deeply and seriously affected. And I'll show to you some of the initial impacts so far. And the region is actually the first one to be hit by COVID-19. As you know, the first case was outside of China, outside of Wuhan, was found in Thailand. And since then, the countries of the region have fought, this unseen virus in many different ways. It's actually a wide range, as you can see. Many countries have been actually lauded by the international community for their early and effective response to the virus. But at the same time, you have countries like Indonesia and the Philippines, which are the larger countries of the region, which have been finding some difficulties in trying to curb the further spread, transmission of the virus, as you can see here in this table. And as I've said, even in the recent Lancet, rankings of the world's countries in terms of their effectiveness of the effectiveness of the pandemic response, you can see that a lot of the top notchers are actually from the region. Thailand, the Mekong countries of Laos, Cambodia, Vietnam, and Myanmar, and Malaysia, and also Singapore should also be there. But of course, the question is, sure, if the response is effective, the region, despite again being the first one to be actually hit, did not become the epicenter of the global pandemic. We know that it is the US and Brazil, and unfortunately India as well, and some European countries. But despite these achievements, we know that migrants, migrant workers and other types of migrants, people on the move, have been left behind by these early successes in the pandemic response. And so, here I'm summarizing what are the indirect impacts. And when I say indirect impacts, of course, migrants themselves become directly infected by the coronavirus. But much more concerning are the indirect impacts of the COVIDization of health systems, of public health, the impacts on migrants. And what are these three? First, and as already insinuated a while ago by the earlier speakers, the aggravation of existing healthcare access barriers. So these barriers, are not new. These have been existing even before COVID-19 arrived in our shores, but definitely the pandemic worsened the situation, the healthcare access situation. Second, neglect and worsening of non-COVID diseases. We know that migrants, as Miriam already mentioned, highly vulnerable to non-communicable diseases or maternal and child health challenges, or tuberculosis and malaria, still unresolved infectious diseases in the region, but also the new epidemic of loneliness and other mental health conditions. And then finally, the exacerbation of dire living and working conditions, which we popularly call in public health the social determinants of health. Their job, the jobs that they're in, which we know as the 3D jobs, the dirty, the demeaning, and the dangerous jobs that usually migrants are subjected into, but also, their access to food and water and other life's basic necessities, especially in refugee camps and in temporary shelters for internally displaced populations. So what are the major headlines in the region? So as I said a while ago, a country like Singapore was able to actually control the spread of the virus, but then it led to a second spike when they realized that they actually neglected the migrant workers, a lot of them staying in these cramped, overcrowded migrant dormitories. They were not initially included in the testing and the tracing and the treatment of COVID-19, leading to a high second spike, around 90% of the cases coming from these migrant dormitories. Singapore eventually corrected these exclusion of migrants in testing and tracing, and then now they've been enjoying low COVID incidents since then. And then the nearby country of Malaysia, which is also, as I've said, a predominantly receiving country, received a host to a lot of Indonesian, but also Indian, Bangladeshi, and Filipino migrant workers. They've been able to address the COVID-19 pandemic among their own citizens. But then when it comes to the migrant workers, some have been detained in overcrowded detention centers, serving as a breeding ground for new infection clusters. They've made testing available to undocumented workers, but at the cost, sometimes even reaching up to $100. And so there's still a lot of challenges faced by migrant workers, even in Malaysia. But in Thailand, which is a country that has been the poster child of universal health coverage globally, Thailand has been putting in place, even before the pandemic, migrant inclusive health financing schemes and health services. As you can see there in the different schemes that Thailand has when it comes to health services. There is an attempt to actually include non-Thai citizens, a lot of them from the Mekong countries, the nearby Mekong countries of, as I've said a while ago, Laos, Cambodia, Myanmar, and Vietnam. But of course, there's still a lot of challenges. But because of this inclusive policy, Thailand was able to actually really, keep the COVID cases and deaths at very low levels. Because of that, again, recognition that the country cannot be, totally protected from the coronavirus if the migrants are neglected and if clusters of infection happen in those migrant communities. But then, if you look at the predominantly sending countries like the Philippines, COVID-19, the pandemic has seen the largest repatriation of overseas Filipinos within a century. The country has an explicit policy of labor export migration. 10% of the Filipino population actually lives overseas. And as you can see here, almost 300,000 of those overseas Filipino workers have been repatriated already. Of course, not without challenges, from delays in testing to prolonged quarantines because of the lack of a clear plan when it comes to how they can return to their respective hometowns, but also the stigma, that these overseas Filipinos might be unknowingly bringing the virus back to their hometowns. And so you have these situations where migrant workers, both the ones from abroad, but also the ones from capital cities like Metro Manila, have been stranded. The term that we use now here in the Philippines is locally stranded individuals, or LSIs, because there's a lot of resistance from the other provinces to receive these, migrants, back to their hometowns. And then the capital has, was not able to plan their temporary stay. And therefore you have these stadiums filled with migrants, again, becoming a petri dish of viral infection spread. And then one interesting story, for instance, which is specifically unique for the Philippines, is that the Philippines is a major exporter of nurses and other health professionals. We are a leading source of health workers, for the United States. And as you can see here in this headline, Filipino nurses are disproportionately affected, if not killed, in places like the US, the UK, and even in the Middle East. And then when it comes to internal migration, now we are seeing the compounding of both, COVID-19 and natural disasters due to climate change. The Philippines is one of the countries in the world most vulnerable to the effects of climate change. And now these people are internally displaced, facing this dilemma: do I stay at home, which is now flooded, or the roof has been blown away by the strong winds, in order to protect myself from the coronavirus, or instead go to these cramped evacuation centers where I will be protected from natural disasters, but at the same time, definitely highly susceptible from contracting the virus because of overcrowding with other evacuees. And then, Anjali already mentioned the issue of the Rohingyas, and we know that the Rohingyas came from Myanmar, which is part of our region. And so this is also an important issue. Now we're seeing a lot of support from international community and also the country of Bangladesh, the government of Bangladesh, in providing information, health services, treatment to the Rohingyas, certainly much more needs to be done. And then finally, one of the most shameful dimensions of migration in Southeast Asia is human trafficking. The region is a human trafficking hotspot. There was a report that even up to 85% of trafficked persons actually originate and circulate around Southeast Asia. And the economic precarity that the pandemic brings definitely puts a lot of impoverished communities, people, IDPs, refugees at a higher risk of being victims of human trafficking. And so the question now is, how can we shift from stopgap measures to durable solutions? We've talked a lot about providing assistance to migrants, whether in terms of testing, whether in terms of food and shelter. But how can we make sure that universal health coverage in these countries, not just in Southeast Asia, but globally, are truly universal, inclusive of migrants and other people on the move? And how can we make sure that migrants are also included in the economic stimulus recovery packages that many countries are now contemplating, passing in their parliaments, etc.? And then finally, especially when it comes to refugees and internally displaced populations, how can we ensure that we address the root causes of these problems so that when a new pandemic arrives, within this century, these populations that are protected from the direct and indirect health impacts of infectious disease pandemic. So yeah, that's it from Southeast Asia, and I look forward to a vigorous conversation with you. Thank you very much.
Thank you, Dr. Guinto. Christy, Braham, if you're happy to take over next.
Hi everyone, I'm just sharing my screen, sorry. Yes. Hang on one moment, it's just doing something for some reason. Let me try again. Apologies. Oh yeah. Can everyone see that?
Yeah, we can.
Oh, fantastic. Okay, great. Sorry. Hi everyone. So I'm Christy. It's great to be here. I'm actually quite familiar with Students for Global Health because I was part of medicine back in the day when I was an undergraduate, which feels like a very long time ago. But it's lovely to be in contact with all of you here, and great to be speaking with fellow panelists as well. So I'm going to focus in on Africa as a continent in terms of the context of the current pandemic. So I'm the founder of a very, very small organization called African Platform for Migration and Inclusion in Health, APMI. And I also I kind of wear two hats. So my other hat is also that I coordinate the health activities at another NGO called Women in the Informal Economy, Globalizing and Organizing, WeGo. And there I work on sort of migrant workers issues. But today I'm going to pretty much wear my APMI hat. So, situation in Africa. So this is a screenshot from the Africa CDC website as of the early hours of this morning. So as we can see, we've got 1.6 million cases across the continent, nearly 40,000 deaths. You can see there's various hotspots here. So that's Morocco, right at the top left there. It's Egypt over there. We've got Ethiopia and South Africa. So we've got sort of major hotspots across the continent. And obviously, there hasn't been a single country that, hasn't reported cases, but I think many people would be aware by now that the situation in Africa is quite different to how it is in Europe and in North America and South America as well. But really, Africa is a continent on the move. Africa is defined by mobility. for millennia, people have been moving for various reasons, for their livelihoods. You know, this isn't just a phenomena that originated with the onset of colonial borders. You know, people have always been moving. It's a part of the fabric of the continent. And so the sorts of movements that we see are rural to urban movements. So this is about people moving from villages to towns and cities within the same country. It's also about people moving to other countries in that region. So for example, so my family are West African, and 90% of all movements within West Africa are people moving to neighboring countries. So people from Nigeria moving to Cameroon, or going to Benin or to Niger, that sort of thing. So it does sort of counteract that narrative of sort of Africans moving to Europe. That's simply not true. You know, the majority of movements are people moving within the continent or within their own countries. Part of this conversation also needs to involve people who are from nomadic and pastoralist communities as well. You know, they've been moving for their livelihoods with cattle, for example, for millennia. I think that they tend to be left out of the conversation, which I think is a bit of a travesty. But nevertheless, when we talk about migration and Africa, many people talk about displaced populations. So more than a quarter of the global refugee population are in Africa, predominantly in East Africa, Horn of Africa. So we're talking about Ethiopia, Kenya, Uganda, Tanzania, etc. And of course, a huge proportion of the world's IDPs, internally displaced persons, are in Africa too. So we're talking about, for example, people in South Sudan. We're talking about people in DR Congo, in Nigeria as well. So the picture is very, very, it's very, very diverse. And I think that that's something that really should be communicated a bit more. So this is just a picture of a refugee camp in Burundi. So you can, I think it's, you know, you can see the sort of conditions that people live in. And of course, there are many, many refugee camps across the continent, as well as informal settlements as well. And this is an example of another working environment where migrant workers may carry out their roles. So this is, for example, a mine in South Africa. And I think that's also quite a good example for sort of the health risks that might be associated with carrying out specific job roles as a migrant. So I'm not going to spend too much time on this slide, because I feel that everyone else who came before me has done such a good job of sort of talking about the sort of generalized risks associated with being a migrant. But here, you know, I've just sort of picked out various different groups of migrants, and I should probably explain that these are not distinct. So of course, some people who are refugees are also migrant workers. Some who are, you know, sort of nomadic are also migrant workers, or people who are trafficked who are migrant workers or refugees. So it's very fluid, but nevertheless, these are sort of broad groups that are spoken about. And there are various barriers and difficulties and challenges associated with being a member of these groups during the COVID-19 pandemic. So, for example, reduced ability to quarantine, self-isolate, and socially distance. If you are living in a informal settlement as a refugee, where you share a tent with multiple other families, and you're living in really close quarters, you haven't got much access to water and hygiene facilities as well. And that has been the case, for example, in multiple refugee camps. For example, in Kenya, there was a report about the number of liters of water that would need to be provided to ensure that people have enough access in this particular camp, you know, to actually prevent COVID-19. So I think that number was something like 40 litres per day per person, and it turned out that in most refugee camps in East Africa, it was something like 10 or 15 litres maximum, and you know, even that's variable. So I think that does kind of illustrate the difficulties there. And of course, there's other things like stigma, discrimination, closed borders, and poor access to healthcare. Although there's a caveat there, you know, there are some countries in Africa, again, alluding to the history of mobility on the continent, there are some countries which are surprisingly welcoming to migrant populations. So for example, Uganda is generally seen as being quite progressive, and almost all refugees have access to healthcare. South Africa, on paper, is supposed to be progressive because it's enshrined in law that every person on South African soil, regardless of citizenship, legal status, should be able to access healthcare. But the on the ground picture is very different. So it really depends on the context and sort of the policies at play there. Right, so here's a quick sort of look at the initial circumstances, because as I said, the picture in Africa has been very different to other places. So when March came along and sort of the pandemic really truly hit, many African countries responded with closed borders, even countries which didn't have any cases at the time. Closed borders, very draconian lockdowns in cities like Johannesburg and Lagos, in Accra, and also lockdowns of refugee camps. So Miriam spoke earlier about how there is that sort of biosecurity lens instead of a sort of public health lens, where, you know, the first step is to sort of just automatically lock down refugee camps without thinking about some of the actual circumstances in which they live and the effects of that. And actually in places like Uganda, for example, automatic lockdowns of refugee camps have led to things such as police brutality, and have led to, you know, various skirmishes and difficulties, and have actually made things quite difficult for certain groups of migrants there. We've also had a temporary suspension of refugee resettlement schemes. So there are many refugees across the continent who rely on the UNHCR to actually airlift them to other countries where they can then begin a new life. And actually those schemes were temporarily suspended. And it's only in the last few weeks that schemes from Libya have actually resumed. So there's been a sort of 6-month limbo for many refugee families, unfortunately. There was also a reduction in programs in refugee camps. So for example, UNHCR refugee camps, and also World Food. The World Food program actually did a serious cut to their programs, which were giving food rations to refugees in Uganda, and this was all sort of in March and April time. Also, anyone who's sort of into humanitarian issues might be aware that Oxfam closed many of their offices across the world, and I think you know, with the economic situation, many other organizations may follow, and so that obviously there may be an impact there. But nevertheless, the early predictions are seen by many as being overblown in some ways. So, you know, of course, we had these very draconian measures and, you know, lots of disruption with programs. However, a lot of that was sort of based on, you know, we predict that African countries will have a huge burden of cases and deaths due to, you know, poor resourcing of their health services, lower quality of care. You know, if you can't provide rations to refugee populations, then we're looking at a massive famine. You know, with lockdowns, people will lose their jobs permanently and they won't get them back again for years. So it's going to be, you know, an economic mess. And actually, a lot of those things haven't actually come to fruition just yet. So there is actually...
Sorry to interrupt, Christy, but it's been 10 minutes.
Okay, so have I got another 2 or 3 minutes just to finish off?
Yeah.
Okay, perfect. So yeah, so those early predictions have actually been subject to debate up to now. But here's the reality. So of course, it seems as if Africa's sort of missed, I guess, the biggest hit of the pandemic. You know, the situation is just not the same as it is in Europe and the Americas. However, everything is very uncertain. Really needs some serious vigilance there in order to prevent a second wave. South Africa, actually, there are lots of worries about a second wave happening there. And also refugee camps are slowly beginning to see some outbreaks as of last week. So things we need to monitor: economic impact. I mean, we all know that we're facing a deep recession globally. However, we've lost incomes from migrant workers, lost remittances that, you know, Miriam mentioned that as well, downsizing for NGO programs. All of these actually impact on migrants' health. So actually, there's also been a rise in suicides amongst refugees in Uganda, for example. So there are some really tangible, early, very worrying early signs of the situation we're facing. Of course, the focus on COVID sort of takes away focus from other things, such as HIV/AIDS, TB. There's been real stagnation in childhood vaccination as well, which is very, very worrying. And of course, when as you know, relating to NCDs as well, cancer care, and you know, making sure that people can have sort of long-term access to the things that they need. It's really looking tricky. And of course, deportations have continued, unfortunately, which is responsible for some of the imported cases. Stigmatization of migrants was never going to stop during the pandemic, has only increased. And unfortunately, many of the issues are due to continued conflict and displacement. So DRC, there's been many, many people who've still been crossing over, and you know, lots and lots of worrying things happening there. But of course, the underlying thing here is poverty and economy. So I think with Africa's economic future looking rather uncertain, as you know, compared to the rest of the world as well, I think as long as that remains uncertain, we're going to see a continuation of all these things which do impact on migrants' health. So I'm going to sort of skip over these things, but this is just a summary of things that are happening on the ground with various organizations, the things you expect. So health promotion, health prevention, you know, working on hygiene measures. At Me, what we're doing, we're building a knowledge repository. So we have been working very hard on compiling all migration and health data from across the continent. And we were about to launch it before the pandemic, but then we thought we would start on a COVID-19 sort of special section. So we're going to launch all of that. We've been supporting our partner on the ground in Sierra Leone with risk communication and also advocacy as well. So we've been talking to migrant communities who've been reporting things that are happening to them. They've been reporting, for example, abuse from UN workers in the camps. They've been reporting not having access to healthcare and various things like that. And that's been really useful for keeping our eye on what's going on. So thank you very much for listening, and anyone's welcome to email me at any point.
Thank you very much, Christy. Over to you, Dr. Sedas.
Hi, thank you very much. Wonderful presentations. 1 second, let me just share the screen. everyone could see this? All good?
Yeah, we can see that. Thank you.
Perfect. So hi from Mexico. Unfortunately, I cannot say please come and enjoy a shot of tequila because we have COVID. But I wanted to share with you the case of Mexico from the field. I'm a physician. I'm currently doing my master's in global health and social medicine, and then COVID-19 came. So it's been quite interesting to be part of the global health family in the midst of a global pandemic. And I also want to share something very important. I will speak from behalf of the people that I have witnessed the suffering in my country. And I want for you to keep in mind that they're people. This is a picture of a family, a refugee family from Honduras. They actually were okay with the picture, but I just wanted to share a little bit about the story of what's going on in the ground compared to what's going on according to the government. So that's where I'm at right now. This is a map of Mexico, and the little pink area there, this is Monterrey, Mexico. That's where I'm from, and that's where I'm at right now, currently trying to do my field work, well, hi from Monterrey. So I wanted to start with something that says history didn't start when you arrived. It's a phrase that one of our professors from the Department of Global Health, Paul Farmer, always mentions. History didn't start when you arrived. And I wanted to add a little bit of a twist. History didn't start when COVID-19 arrived. And what is happening right now with COVID-19 in the migrant population? So we're talking about a country that has a constitutional right to access healthcare. And we're also talking about a country that has signed international treaties supporting the right to health. Having that in mind, as of October 16, we have only tested 2 million people, and we have experienced 85,000 deaths and 841 positive cases. So this is very troubling because although the statistics and numbers are extremely high, international outlets and national outlets say that this is very much under the umbrella of we're not testing enough. In Mexico, there was a report recently that we have an excess mortality of 100,000 people, 200,000 people. So I am going to talk about what is going on in the field. So to very much understand the lack of access to healthcare, I really want to talk about what is healthcare in Mexico. So in 2015, we had something that's called Seguro Popular. So Seguro Popular was a publicly funded, decentralized health insurance plan that said, okay, let's help everyone. In Mexico, we have different health insurance, and we need to help people that don't have access to a private insurance or any other insurance under their jobs or under whatever they work, either in the Navy or they work as teachers or around that. So they designed Seguro Popular, and they covered about 50 million people that were previously uninsured in Mexico. They have access to primary, secondary, tertiary care for free. And they even covered catastrophic expenses. So if you had cancer, you had treatment for cancer long-term. And migrants were included in this package. So migrants were covered for 90 days. 90 days seems a lot, but when you actually think about the time a migrant spends in movement from Mexico, from Tapachula, Chiapas, all the way to northern border cities, it's about 90 days if they take the Beast or the train track, how they call it the Beast. So since 2019, migrants were in a situation where there was a change of government, and then there was a militarized approach, and they could either go right, and if they go towards the right part of Mexico, it was a shorter route, but it was more insecure due to organized crime. And if they go through the left, it was longer, the journey was longer, but it was even, it was really hot. So that was a little bit of the situation. And then INSABI came in. So INSABI is a federally funded centralized health insurance plan. But in 2020, January 2020, there was an increased budget cut. So caring for more people with less money. And then they also had personnel cuts. So caring for more people with less people. The expectations were, let's just include everyone, increase the number of people that we could cover. But the reality is that there's a severe exclusion, especially for very vulnerable populations, migrants included. So how are migrants included in this new approach? In theory, migrants are included in the National Comprehensive Plan. However, there are no details on how this will be covered. So a little bit about what was happening in 2015 when we had Seguro Popular. So there was a study conducted by LEIBA in the entire national territory in 2015. And they found out that 6 out of 10 migrants who needed care sought care in 80% of them migrant shelters, 3.7% traditional care, 3.5% private medical care, and then 1.8% government-funded primary care clinics, when in theory we had free access to healthcare for 90 days. So migrants continued to opt for migrant shelters, but why? I want to show in 2018 the phenomenon that in Mexico we categorized as new, but migration has always been very present in our country. So this is movement in 2018 from migrants, where we used to think that it was only men, but now we started to see a shift in demographics. We saw women, we saw children, we saw adolescents, elderly, people from African nations, from the Caribbean. And it was very, very interesting, the phenomenon, but it was even more interesting how there was so much it was such a politicized environment, and migrants were severely restricted in movement. So starting from there, in 2019, the IRC conducted a needs assessment report. And the main concerns, if we recall that 80% of migrants wanted to or preferred to get care in shelters, they asked migrants, what are your main concerns? And some of them said, feeling unsafe to leave the shelter, limited freedom of movement because the police officers outside, or the federales, they would see you and they will try to intimidate you to either get money or try to do some other things that are not really in the freedom of movement type of area, if we could say. The cost of medical care. You have a country with free healthcare, and it's extremely expensive to access healthcare. And they didn't know that they could be assisted. I had a conversation with a young man in a shelter in Tijuana, and he said, I'm expensive. I am expensive, and I don't know if I have the right here to get medical care. So those are the type of conversations, and no medications are available. Actually, right now in Mexico, we don't have immunizations for children, and women are not able to immunize their children once they're born, and they have to go and scramble for whatever is available. 36% of migrants experience barriers to access healthcare. And the question is, what is going on? So since 2019, the Mexican government defunded all shelters to centralize care towards a federally funded mega shelter. But why? The question is this an unintended consequence of health reform, that migrants are not going to to get medical care? Or is this a form of planned structural violence or unplanned structural violence? So this is a very interesting chart that I really spent a lot of time doing, and I had a lot of fun. We were able to see the shift of the magnitude of migration in Mexico. So in 2019, the migrant caravans came in, and we saw about 1,148,000 apprehensions at the US-Mexico border. And it was very interesting because when we started with the pandemic, borders were closed. The US and Mexico relations were very tense, and we didn't see a lot of people in Mexico. But what was the reality? We had huge numbers of people. About 600,000 people were apprehended at the US-Mexico border. So where are they? That is the question. So there's a huge change in demographic and transit migration through Mexico. At first, in 2018, we saw a lot of families, a lot of single male and men and women. And in 2019, we had a spike in family units and a little bit more of unaccompanied minors. And then in 2020, although the statistics, these are numbers from the US Department of Homeland Security, although they say that single men are most common, in the shelters, having conversations with the staff, there are a lot of families coming in. They see about 4 or 5 families a day with children. So what is going on? What is this discrepancy? So they're trapped in this limbo of political instability, and what are we going to do? So it's very interesting to see that in the midst of a global pandemic, there's an increase in deportation events. So from March to September, there has been 49,000 deportations from the US to Mexico. But then Mexico did the same. And from March to August, they have repatriated 119,000 people. And then what is happening? There's movement, everything is closed, and people are not able to access healthcare as well. I'm not going to go into detail, as all of my other colleagues have mentioned it before, but it's very interesting how asylum claims have increased in a country where our health system is severely strained and where the actual pandemic is hitting. So why are people staying in a transit country? Mexico transitioned from transit to a resettling country, but does it have the infrastructure to actually care for the rights of every single individual if they don't even have the infrastructure to care for the rights for their own citizens? So international agencies have demanded a halt to such deportation practices as they might overturn already fragile health systems, not only in Mexico, but in Central America and South America. So this is a little, I wanted to just show this while I talk about some cases that I have been experienced, but you might see that there's this gap between June and September that nothing has been going on. But the reality is that reporting on migration very much ceased from the media. There was a complete silence. If you dig through, you will find a couple of cases here and there. But the problem is 30 in total, in the pandemic, where we have hundreds and thousands of people dying in our country, only 33 migrants have died. Only 33 migrants have died. And I would be ecstatic to say only 33 migrants have died, because that means that we're doing something for this community. The reality is that the only way of knowing how many people died due to COVID-19 is to actually get tested, but not even that. Migrants are not getting tested. There's no testing, there's no isolation, there's no infrastructure for quarantine. There are a couple of isolated events that there were very, very, very interesting. For instance, the IOM put some Hotel Filtro. There was a hotel that they put, they enabled migrants to come in, quarantine there for 14 days, and then continue their transit. The reality is that this is not heterogeneous around the entire country. This is isolated events of good practices. But the reality is that although the Mexican government says that there are only about 17,000 migrants, this was around March, there are only 17,000 migrants, and most of them are Mexicans. The reality is that shelters, northern border cities, are saying we have at least 25,000 migrants living in very dire situations without access to healthcare and without access to clean water. So what is going on? I could tell you 2 cases, 2 women, both of them with children, and I would say infants to newborns. And then in I would say a month, I saw this woman, she was from Honduras, and I saw a post on Facebook. Someone was saying, hey, she needs help. And
sorry to interrupt, Dr. Sedas. It's been 10 minutes.
That's part of the story.
Okay.
So I could go back with the cases later, but what I want to say is that how can we create a system that is inclusive if it's extremely exclusive of the most vulnerable people? And not only migrants and refugees and asylum seekers, but even the local community. So we have a lot of lessons that we need to learn from neighboring countries. But the most important thing is to actually include the most vulnerable by listening to the most vulnerable. How can I help? As global health leaders, we need to talk to people. And that is something that I've had the very much privilege to experience during this pandemic, in the middle of trying to have my thesis fulfilled and working around migrant inclusion, talking to people. So with this said, I would like to just close with this image. This was taken last week. And although we have 1/4 of a mountain in physical distance, that was a very bad joke. I think that is important as global health practitioners to be aware that we need to physical distance from our patients at the moment. We need to write, but we also need to remember that we need to be present. We need to be there, and we need to see and witness what is going on, because we will be reporting from the field. We will be reporting, and we will be trying to include everyone, so we will not leave anyone behind. This woman, she is not a migrant. She is a local member of the community. And it's also critical to, at the same time we advocate for the inclusion of migrants and refugees, we also need to think about the internally displaced and those who are offering a space for migrants and refugees to live in. And with that said, thank you very much. And I hope it was fun.
Thank you very much, Dr. Sedas, and thank you to all the speakers. We're running a little bit short on time. We've got just under 10 minutes left. So I thought a nice way maybe to end this discussion would be an open question to all of the speakers. Are there any examples of positive responses to migration during COVID-19 around the world? And do you think these offer any potential solutions going further ahead?
Thanks so much, Will. Yeah, I'm happy to give a few examples, and thanks for all the inspirational presentations from all of the speakers. It's been a real pleasure. I think that actually one positive that I would foresee, hopefully, that will come out of the pandemic more broadly, is that I feel like there is an increased awareness of how much our societies rely on and have integrated migrants within them. You know, I think there is an awareness that, you know, our societies depend on key workers, our health systems depend on a lot of people migrating into the health service. So I think that there may be an ability to build on that and to use it as an opportunity to perhaps change the discourse, or attempt to change the narrative a bit on migration, so that people can realize how integral it is to our societies. But in terms of some sort of concrete positive examples, you know, with regards to including undocumented or irregular migrants within the health system response to COVID-19, Portugal has actually been fairly progressive in that they have given permission for residency and also full access to public services for all of those who are undocumented or irregular status. And also there are examples, for example, in Spain, as well as to a certain extent in the UK, of releasing, at the beginning of the pandemic, of releasing detainees from the sort of conditions which they were living in, which were not conducive or acceptable for public health, especially during COVID-19. So there are some examples. However, I would stress that I think that those sort of positive examples need to be very much strengthened and also shared and followed across the world, because certainly these trends of detention and deportation increasing during a public health emergency is not the way in which we are going to be able to overcome this pandemic effectively or include those who are most marginalized.
I can speak next. Yeah, and I want to speak from more of a sending country perspective. As you know, I'm from the Philippines, a country with a long-standing history of labor migration. And two things. One, we've seen how important strong diaspora communities can actually help address, for instance, the challenges, the vulnerabilities of undocumented workers, for example, in the many places where Filipinos are in. We have, as I've said, more than 10 million Filipinos scattered across 200 countries and territories. And, we've been seeing in Facebook a lot of these networks of migrants really helping each other, providing assistance for those who have been badly affected. And then the other part is while the governance of migration is far from perfect, the country, and partly because of its explicit economic policy, for exporting workers, we've seen how for instance, embassies and consulates have been rapidly mobilized to ensure that the health needs and other types of needs of migrant workers are being addressed. Also, we were able to mount, again, as I've said a while ago, the largest repatriation that has ever been conducted ever. Of course, with a lot of challenges as well, but 300,000 Filipinos already made it back home. And so those are just some examples. For sure, more needs to be done, but this provides some template for other countries that have been sending a lot of migrants and that plan to send more migrants, especially in this day and age of globalization.
Dr. Sedas, did you want to comment?
Yes, I was just going to say that I think that something that has been wonderful is, and important to highlight, is the role local NGOs have had, the local response. Although isolated, when we see the full picture of a nation, of a country, highlighting the critical role local organizations have played to include migrant communities in the response has been spot on. I could give an example of the local organization I'm working with, Casa Monarca. They actually have the project of UNHCR. They are receiving all refugees from Mexico and sending them to Monterrey, as Monterrey is a state where they have, it's very industrialized. So something that was very interesting to see is how to include migrants within the local community as they are resettling to avoid this type of stigma and scapegoating. So one of the things they did was, we need to make them part of the community. So in Mexico, there was a shortage of face masks. And what they did was, we're going to give refugees and migrants all of the equipment to make, and we're going to teach them how to make face masks. And then as part of a project, refugees were working together, making their own face masks, and then they donated them to the local community with a note. So it was part of this inclusion, this weaving into the local community that will become home for many people and will become an area where you have cultural exchange, where you're able to find a job and opportunities and friends for your kids. So I think that that is a critical thing that COVID-19 has left us. At least I could talk about Mexico, Central America, and South America, is that sense of we are all in this together and we have this collecting suffering, and we could all work together because there's no one above us or below us. So I think that the civil society and activist organizations have done an incredible job in advocating at Congress, advocating with policymakers to try to include the most vulnerable and not being explicit on only refugees, only asylum seekers, only migrants, irregular migrants, but everyone, and even advocating for the local community that if a migrant is not able to access healthcare, it's impossible to access healthcare. It's not only a migrant, it's everyone. There's a problem with the system. So how to fix the system? And that I want to really highlight about the case of Latin America.
Thank you very much. Christy, would you like to comment?
Yeah, sure. So I guess I want to kind of build on what Anna was talking about. So the idea of solidarity, I think that's been really powerful in my view, because what I've seen is in the face of, for example, I'm going to use South Africa as an example. So I mentioned that, you know, in principle, foreign citizens in South Africa have access to healthcare, but South Africa also has a very clear and quite worrying history of xenophobia. And so actually at the onset of the pandemic, they did a very Trumpian thing and built a wall between Zimbabwe and South Africa to stop Zimbabweans coming to South Africa, even though South Africa was the place with all the COVID cases. Nevertheless, in the face of all of these sort of very dangerous policy ideas, you had lots of solidarity from citizens and small NGOs who opened up their doors to welcome refugees who've been thrown out, to welcome migrant workers, foreign migrant workers from Congo who had, you know, weren't able to sell on their stall because the government had said, oh, it's the foreigners who are bringing in the disease, and, you know, people who'd sponsored migrants, you know, to get some access to healthcare. And so I think in the face of all of those things, I think that's been a really critical thing. So that's probably my little glimmer of hope.
Thank you very much. And Dr. Borhade, would you like to comment?
Yes, well, thank you so much for very interesting presentations and insights around the world. I would like to share my, experience and a realization during these COVID times. I mean, we keep saying that there should be multi-stakeholder partnership to address migrants' health issues, and we should also focus and support migrants' health, but also address the social determinants of health. And I saw that happening during COVID times in India, and I'm sure in other countries maybe. But in India, we have seen that, you know, the health department is providing all the COVID support services and facilities, but alongside other departments are equally contributing to health department in terms of linking these migrants to social security assistance or providing them shelter and basic amenities, and, you know, even addressing the other health issues, including the mental health support in tie-up with civil societies and other agencies. So I saw that that's actually happening, you know, that dream idea or the dream recommendations to address migrants' health. And I wish, you know, this should not remain as a short-term initiative just during COVID or post-COVID, but it should become kind of a long-term feature to support migrant workers in with a holistic approach.
Brilliant. Thank you very much. So collectively, we've run out of time now, but collectively, I would like to say thank you to all of the speakers on behalf of Students for Global Health and all the attendees. That was really, really interesting conversation. And we've had a lot of questions on the Google Doc. So I'm hoping if you guys can spare a little bit more time, you might be able to answer some of those just on paper. But yeah, I want to express my deepest thanks, and yeah.
Thank you so much, everyone. Thank you so much.
Thank you very much.
Thank you, Will, and thanks everyone.
Gracias.
Ciao.
Good night, everybody. Stay safe.
Bye.
Thank you.